type of program continuously, but your feedback is important for us. So please just log in to gujaratcriticalcare.com or download the application Gujarat Critical Care in Android, and there is a feedback form. Just fill it up and it will take around 2 minutes. So please do that. That will be our request. Thank you.
With the help of ultrasound in the intensive care or in the emergency department.
So for panelists here, Dr. Shastri, sir, there are questions for you also.
Which come across your mind. The first thing is that there is a dual pathology going on. Maybe there is a background of anemia and she's developed acute distress, which is not necessarily related to anemia. And this could be two different pathologies. The other thing is obviously, like Dr. Soren said, that these are all a part of the same thing. And hence, if we consider this as the same etiology, because we're going to go towards alveolar hemorrhages, then I'll start thinking about what are the common causes in my part of the world which would lead to this kind of a situation. So I'll start thinking with infections also, although there is no history of fever there, but virals, malaria, leptospira, things like that. I usually think of a cardiac disorder here as well. This is a young female, although there is a history of joint pains which was recent, she could have had rheumatic fever and it could have led to valvular heart disease. Systolic or diastolic heart failure because of cardiomyopathies could come up with a bilateral shadowing with hemoptysis in this patient. So cardiac disorders. Sometimes drugs, but not very common in our part of the country, but sometimes there are certain drugs, but not very common. And last and not the least, would be obviously the connective tissue disorders, vasculitis kind of profiles. So from those aspects, I would start thinking about my workup. So I would look up for virals and infections, I would look up for a cardiac disorder, I would look up for some drug toxicities, and then I would look at the collagen workup.
Also, that of 3 days duration, facial puffiness since 2 days, and streaks of hemoptysis since the morning she presented to the emergency room. Her shortness of breath was grade 2 to start, progressed to grade 3 in less than 24 hours, but does not indicate paroxysmal nocturnal dyspnea. She doesn't say that she's got chest pain, but has occasional cough. She noticed facial puffiness in the morning of the second day of the onset of symptoms, which is varying towards the evening, and the same day she noticed a high-colored urine. In the past and personal history, she's had 2 episodes of joint pains involving both hands associated with fever in the last 6 months, but never evaluated, which was relieved according to her description with paracetamol, but had redness of face during the second episode of fever and joint pains. Personal history: she's an active lady, walks every day, but has been unable to sleep well for the past 3 days because of the shortness of breath and the cough. And she denies any significant drug history, including oral contraceptive pills. On arrival, she is mildly febrile at 99.4, has a tachycardia at 120, which is reported to be regular. Her blood pressure is a little higher at 130 or 90. She is tachypneic at 28 per minute, saturating 85% on air, improving to 93% with 4 liters through the face mask. On auscultation, both her heart sounds are heard with no murmurs or additional sounds or pericardial rub. On lung auscultation, there are bilateral basal crackles with no pleural rub heard. Abdomen-wise, there is no organomegaly or tenderness, and no neurological deficit could be found. Because of her blood pressure being high, a fundus examination was done in the emergency room, which shows small punctate hemorrhage on the right side, but no edema on the disc. Musculoskeletal system, because she complained of pain in the joints in the past, revealed nothing except for diffuse swelling of metacarpophalangeal joints of both the hands, but the movements of those joints were not limited. Some labs were done in the emergency room. Her blood picture shows a hemoglobin of 6.8 grams per deciliter, an elevated leukocyte count with a little bit of polymorphonuclear preponderance, and a peripheral smear which is normocytic hypochromic with leukocytosis, but there is no left shift and no bad forms were reported by the pathologist. Blood gas showed on 4 liters a PaO2 of 55 and a respiratory alkalosis with no metabolic acidosis and a normal lactate value. That's an ECG, which I'm sure most of you can see. There is a right bundle branch block on the ECG. And an X-ray was asked for in the emergency room, which shows bilateral infiltrates. sparing the apices of both the lungs. Costophrenic angles appear to be normal. Cardiac shadow is reported to be normal by the radiologist. So, Soren, these two questions for you. What would be your differentials for this young lady who comes with a short history, a short of breath, with some rheumatological manifestations and sleeping hemoptysis? We have done a few basic investigations, and what would you do next for this patient?
Hello. The clinical scenario which Dr. Srinivas presented is basically a patient who is dyspneic, fever, and there is also history of hemoptysis. And along with that, there are joint pain for some duration. So all these actually points towards some kind of collagen vascular disease associated with the pulmonary, whatever is the problem, maybe the involvement with the lung parenchyma. So keeping in the possibility whether this is most likely a systemic, some kind of either vasculitic syndrome or collagen vascular disease with involvement of the lung, that will be the defined cell. Obviously, I will. It can be sometimes precipitated by some new infection because patient was having 6-month problem, and sometimes some infection can precipitate or exacerbate the situation. That may be the basically added scenario.
Anything else you would want to do next?
Other than that, there are so many possibilities, particularly kind of some of the infections that are created with the systemic manifestation that particularly tropical country. So you can keep so many possibilities, particularly rickettsial disease. Then there are pulmonary leptospirosis that can also present like some kind of viral infection and also cause hemorrhage. So these are the some of the and I think that sometimes there is basically collagen vascular disease associated with vasculitis is also a possibility. And this patient has anemia also. So we should also keep the collagen group. We should just keep SLE or sometimes mixed connectivity should disease or sometimes overlap should disease or mine. And about what to do next. Actually, this patient is who is hypoxemic and having this clinical scenario with anemia. So I thought according to that we should actually fight the hypoxemia. For that we can go to oxygen, then non-invasive ventilation we can also offer because this patient is sponsored by oriented. And then along with that, if the patient can be managed fine, otherwise if the patient even with that cannot be managed, then we will look for the invasive ventilation. And that too with the primary diagnosis. For particularly this patient was another urine was basically I think there was some urine problem also, though there is no reported lab diagnosis. So if it is a systemic vasculitis sort of thing, then we should also actually hit with either steroid or some immune suppressor. Otherwise, this patient has enough potential to deteriorate very fast. And along with that, we should also fight the anemia because hemoglobin is only 6.5 or 6, so then we should also try to build up hemoglobin at least 7 to 8 or more than that. Particularly when this is more symptomatic, we should increase it. So whether to give antibiotics plus that depends on the superiority.
Dr. Ranjit, would you like to know something more about the history of this patient and from the clinical examination of this patient?
So basically, there are two issues here. This patient has a very short history, we said 3 days, and the hemoglobin is 6.8, and she doesn't give any background history, seriously with anemia, so it's going on for a long period of time. So when we start off, obviously this discussion is about ambular hemorrhage, and we lead to that, but I don't want to focus on that for the purpose of the crowd. So when you see this patient, there are two possibilities which come across your mind. The first thing is that there is a dual pathology going on. Maybe there is a background of anemia, and she's developed acute distress, which is not necessarily related to anemia. And this could be two different pathologies. The other thing is obviously, like Dr. Soren said, that this is all a part of the same thing. And hence, if we consider this as the same etiology, because we're going to go towards alveolar hemorrhages, then I start thinking about what are the common causes in my part of the world which would lead to this kind of a situation. So I'll start thinking with infections also, although there is no history of fever there, but virals, malaria, leptospira, things like that. I usually think of a cardiac disorder here as well. This is a young female, although there is a history of joint pains which was recent, she could have had rheumatic fever and it could have led to valvular heart disease, systolic or diastolic heart failure because of cardiomyopathies could come up with a bilateral shadowing with hemoptysis in this patient. So cardiac disorders. Sometimes drugs, but not very common in our part of the country, but sometimes certain drugs, but not very common. And last and not the least, would be obviously the connective tissue disorders, vasculitis kind of profiles. So from those aspects, I would start thinking about my workup. So I would look up for virals and infections, I would look up for a cardiac disorder, I would look up for some drug toxicities, and then I would look at the collagen workup.
So there are some more labs which came in as we were sharing our oxygen drive. Blood urea is 84 milligrams per deciliter, creatinine is 2.3. Mild transaminase elevation, AST more than ALT, with an albumin of 2.4. CUE showed no pustles but plenty of RBCs with 3+ proteins, granular crust, negative for nitrates, and a procalcitonin was done which was reported as less than 0.5. Blood cultures were drawn and connective tissue disorder profile was sent. So this is open, any of the panelists can take this question. How would you use lung ultrasound to narrow down the possibilities in this patient? And if you choose lung ultrasound, what would you expect to find on lung ultrasound? Any of you.
So I'll take this, okay. So firstly, I think there's enough to say that there's a background of connective tissue disorder because 6 months of fever, joint pains, and facial puffiness indicates a renal problem. So it's a pulmonary renal syndrome. I would put it as pulmonary renal syndrome and give a differential diagnosis of pulmonary renal syndrome because there is a intraalveolar hemorrhage. I think Goodpasture syndrome and Wegener's granulomatous, these two should form the top. So lung ultrasound, what do I use lung ultrasound for? To distinguish between a cardiac, LVF and a consolidation, and that can be done using the lung. We just now A profile and B profile. If there's no P profile, if there is a C profile or an A prime or a prime profile, then I would think it's consistent with my diagnosis of a Goodpasture syndrome. And I might also find some pleural effusion, but that's usually not there. In an intraalveolar hemorrhage of Goodpasture, it's usually a consolidation. And so then, of course, if I'm allowed to say, I would proceed on to do a bronchoscopy. Right.
Can I take that? See, this patient is probably going to get breathless more and more down the line, most likely, because this is just a baby. She's just entered the ER, and we have a very narrow therapeutic window there. And frankly speaking, we need to reach a definitive diagnosis because she might worsen. Now, obviously, the ultrasound is bedside, and you would look at the heart and you would look at the lung. But what we need to do is to reach a definitive diagnosis. So frankly speaking, just because this is an ultrasound symposium doesn't mean that is the investigation of choice. So you get a CT done here, because after some time, she would be so breathless that you would lose the opportunity of doing it. And because without a CT, a bronchoscopy might be difficult, I would proceed for a scan at this point in time.
So,
just I would like to make one comment regarding the choice of CT ultrasound. Here we are not going to have a definitive treatment.